Hello, I'm Dr. Carol Baker, Professor of Pediatrics at Baylor College of Medicine and a Pediatric Infectious Diseases Specialist at Texas Children's Hospital in Houston. Today we will be discussing MRSA in the community, best practices for early management and treatment. I am joined by my colleagues, Alpesh Amin, to my immediate right, Professor of Medicine at the University of California at Irvine, and Dr. Tom Feil, Professor of Internal Medicine and Head of Infectious Diseases Section at Northeastern Ohio University's College of Medicine and Chief of the Infectious Diseases Section, Summa Healthcare in Akron, Ohio. Welcome, gentlemen. Before we begin, please take a moment to complete the two-question pretest. This will help us to measure the effectiveness of this continuing education activity. This activity will address these questions within our presentation. Let's go over our learning objectives for today. First, to identify best practices for early and accurate identification and management of MRSA skin infection in the community setting. And second, to select appropriate antibiotic therapy for patients with primary and recurrent MRSA skin infections in the community setting. And now we begin with a case from Alpesh.
Thank you very much. It's a pleasure to be here. It's my the case that I'm going to present is a 25-year-old football player with a painful boil. This 25-year-old football player presented to the office complaining of a low-grade fever and painful boil on the left forearm. Patient did not have any chills. The lesion started out as a red rash and then progressed to become a boil. Patient was initially treated with an unknown antibiotic. The patient returned then to the office setting because of this painful boil, complaining of pain. On further history, it was found that several other team players on the patient's football team also had a similar skin infection. Past medical history was unremarkable, except for taking some unknown antibiotics recently. On exam, temperature was 37.4 degrees Celsius, pulse was 70. Blood pressure is 120/70, respiration 14. As you can see on the picture here, the patient's forearm had firm swelling of the left forearm with boil, with surrounding erythema and pus. It was non-fluctuant, but there was severe pain on palpation. The laboratory findings showed a white count of 12,000 with no bandemias. Serum creatinine was 1.0. The gram stain, as you see here, showed multiple gram-positive cocci clusters, and blood cultures were sent off from the clinic setting. So at this point in time, it's worth asking some basic questions. Are we dealing with a complicated or an uncomplicated skin and skin structure infection? And how do you decide whether you're dealing with how do you define it, and how do you determine whether you're dealing with a complicated or uncomplicated skin infection? And one can think about this in terms of grades of infection, if you like. We have superficial skin infections, such as impetigo. We have more deeper skin infections such as erysipelas and cellulitis. You can also have skin infections that can be uncomplicated but still have evidence of abscess. One of the more important things that we think about is whether there are systemic symptoms versus non-systemic symptoms. And in our patient's case, we were lucky enough to see that the patient, even though he had localized pain, but really didn't have a significant white count, did not have a significant fever, and so I would tend to think that this is more of an uncomplicated skin and skin structure infection. But another thing that becomes of interest here is to think about this in terms of whether it is severe or not so severe.
Alpesh, I think the points that you make are very important because they are going to impact our decision as to whether we need to admit this patient to the hospital for optimal management, or can we safely treat this patient in the outpatient setting, which for many reasons we would prefer to do. And from a regulatory standpoint, we tend to consider complicated cases as those that are associated with deep skin involvement or that are going to require significant surgical intervention, drainage, or excision of tissue, or, as you mentioned, are going to be associated with conditions such as diabetes, for example, that may complicate the response to therapy. But I also like to think about it from the standpoint of, do I think this patient needs to come in the hospital or not? And the points that you made, I think, are very important. Because if you have significant systemic manifestations of disease and, fever or chills, if you have a high white count that suggests that there's significant host response, and particularly if there's concern for deep infection. And in a patient like this, sometimes I've been fooled where if we do ultrasound of the patient, we can see that there may be actually a deep fluid collection for which significant surgical drainage may be required. So I think these classifications are very important from the standpoint of the initial management.
Well, gentlemen, if you would allow me, I'd like to make some comments about the pediatric aspects, because we see many MRSA infections in pediatric patients, and the majority of them are skin and soft tissue structure infections. So in our situation, if the infant was less than 2 months of age, a fever like this 25-year-old had would mandate, even just the fever itself, even if the baby looked pretty well, with a localized skin infection like this, hospitalization and a full, what every pediatrician knows as a sepsis workup, which would be at least a blood culture, probably not a spinal tap. And so even without a big abscess or a big cellulitis, a simple abscess like this in a young baby less than 2 months of age would always result in hospitalization and evaluation. And then depending on the clinical course, the duration would be decided. And if you're between 2 and 6 months and you have no fever or whatever, that's pretty much the abscess would have to be less than 1 centimeter, which is not very big, to allow them to go home. But that's a big gray area in clinical judgment. And I think once we get to the healthy child or adolescent, we would have the same comments that you have in terms of decision and definition. But again, even the older child with an abnormal immune system, and here we're talking about some children with diabetes, but our biggest immunocompromised patients tend to be our patients who have cancer chemotherapy, that we would be much more conservative.
So at this stage, it's probably worth asking the question of what, in this 25-year-old football player with the painful boil, what are the most likely organisms causing this uncomplicated skin and skin structure infection? And then once we think about the microbiology, then how do we distinguish it on physical exam, and what are some simple thought processes we can go through? And I guess just to start off, the two biggest infections that one would think about, at least in the adult patient, and Tom can chime in here, but it would be a Staph aureus kind of infection or a streptococci kind of infection. And obviously, when you're thinking of streptococcus, you could think of either Group A or Group B, where one might be associated more with necrotization, and you worry about that. And certainly we know that diabetes is underlying risk factor for Group B infections. But also gram-negatives are part of the thought process, just to be more complete, where you might think of even gram-negative aerobic infections such as Pseudomonas. You might also even think of anaerobic infections such as bacteroides. And it's physical exam can actually be quite helpful in terms of thinking through this. The way I think about it is that if I start seeing lumps and bumps and pus coming out, then I'm thinking much more likely that it's probably Staph aureus than strep, but certainly it can be kind of tricky to figure that out.
No, I agree with you. Although in your presentation of this patient, I mean, we have that positive gram stain, which is very helpful to us, particularly in the field of infectious diseases. We like to do pathogen-directed therapy, and if we see that type of gram stain, I would be confident that we're dealing with a staphylococcal infection, although that does not rule out that you could not have dual infection with a beta hemolytic strep. I mean, when we don't have a suppurative skin and soft tissue infection, it's just cellulitis, then certainly we tend to think more of a beta hemolytic streptococcus. But those patients can also have MRSA as well. And of course, since we're focusing on MRSA, now that we know it's most likely Staphylococcus, we know with the emergence of MRSA now in our communities that is overwhelmingly going to be the predominant pathogen, which is going to have a significant influence on our initial antimicrobial therapy.
Right. You know, and then on the adult population, one of the other questions that can come up in this is what are some of the risk factors for MRSA infections? What are some of the types of infections that we see, and how do we differentiate between community-acquired MRSA, which seems to be a growing burden for us compared to our traditional healthcare-associated or hospital-acquired MRSA? And maybe just to start us off a little bit here, we tend to think about MRSA, and you know, even coming from this probably gets back to us thinking about, you know, whether we should actually admit the patient to the hospital versus not also. But risk factors for MRSA infections include certain types of patients, such as IV drug users, men who have sex with men, folks in pretty crowded conditions, such as prisoners or folks in the military. Even in our case, this football player who's part of a team-based sport would be at risk also. But also patients that are part of facilities like nursing homes are patients that are at risk for MRSA, and this becomes a very important differentiation point, especially when patients are coming into the clinic or into the emergency department as we're thinking about resistant organisms. And then now with the differentiation between community-acquired MRSA and hospital-acquired MRSA, it's probably becoming important that we try to distinguish these in our minds, because certainly community-acquired MRSA may be more susceptible to certain types of antibiotics than our traditional hospital-acquired MRSA. Patients tend to be younger with community-acquired MRSA than hospital-acquired MRSA, and community-acquired MRSA patients have a unique toxin, the pantene-valentine leukocidin toxin, which is not usually found in the hospital-acquired MRSA. So there is some differentiation features amongst these types of MRSA organisms.
Yeah, that's absolutely true, Alpesh, and I think the risk factors that you mentioned certainly have a higher association with MRSA, but to be very honest, in our clinical setting now, even patients who don't have those risk factors, we find that the predominant pathogen is MRSA. So to me, it's less relevant now, although I think it's helpful to ask about those questions, and also if there's other family members who may have had similar types of infections, because that's a big risk factor as well. And of course, regarding the differentiation between community-associated and hospital-acquired, this is becoming more blurred now as we see more and more patients in the community who have some type of association with the healthcare setting, but maybe never have been in the hospital, who could have the hospital-acquired strain. And then many patients in the hospital now, in our setting, about 50% of the MRSA in the hospital are the so-called community-associated. But it does make some important difference for what you mentioned, and that is the difference in the susceptibility pattern. And I think, from an epidemiologic standpoint now, with the blurring, it's difficult to make that distinction. I think the way we can do it is from a molecular or a genetic way, by looking at whether this is a USA 300 strain or if it's PVL positive or et cetera. And I think that's probably how we'll be doing it in the future.
But what I heard from you, Tom, was that probably in all of these kinds of cases, we got to be thinking, or number 1, 2, and 3 things to think about MRSA, and MRSA.
I agree totally.
Yes, in children, it's interesting at the Texas Children's Hospital down the street in the inpatient and outpatient setting, the MRSA, the staphylococcal infections are about 80% MRSA now.
Wow.
And the other interesting thing in our hospital that we're noticing using molecular studies is the USA 300 clone. Some of the genetic material is jumping back into the methicillin susceptible Staph aureus strain. So stay tuned because this is very blurred, and I think things will change. A couple of risk factors. You mentioned crowding. In children, that includes daycare attendance. That puts you at more risk for almost any infectious disease, but also obese children, and I'm talking about morbidly obese children, are much more likely to have MRSA infections than more slender children. And of course, the contact sports begin at an early age, and I never thought of wrestling as a contact sport, but it's very much a contact sport because of the mat and the abrasion of the skin.
In our patient, this 25-year-old, again, with the football player, it probably is, before we start getting into management, just it reminds me of the St. Louis Rams. There was an article published in New England Journal of Medicine back in 2005 where 9% of players were found to have this so-called community-acquired MRSA. So it was a real situation, a real case with the professional football team, and many of those had the positive PVL. But let's move on to thinking about some of the management strategies for a patient like this with uncomplicated skin and skin structure infections. The first question obviously is, do you remove the pus? That would be your first step in most situations. And then we certainly have certain types of antibiotics that are useful in management of uncomplicated skin and skin structure infections. But one of the ways to think about this is first whether the patient actually looks sick or not. And if the patient has no evidence of systemic signs or symptoms, one would, after considering the need for IND and getting wound cultures and trying to do pathogen-directed therapy based on the cultures, one would think about the antibiotics that they would choose. And in a patient who's got uncomplicated, without evidence of fever or white count, you would either discharge them with appropriate close follow-up, or may consider a course of oral antibiotics with follow-up in 48 to 72 hours. Whereas if we were dealing with a more sicker patient with more systemic signs and symptoms, fever, white count, one might think of some IV antibiotics. And we'll talk a little bit more about the antibiotics as the options are Bactrim, clindamycin, depending on the D-test of the organism, as well as tetracycline or doxycycline would be the antibiotic options here from an oral perspective.
No, I agree, and I think the issue of treatment for very simple abscesses or carbuncles or boils or furuncles, using IND alone versus IND plus antibiotics is not clearly defined.
Right.
I think in this patient, let me just go back and just say that there are some large randomized trials that are looking at that to try to define, is it really important for us to give antimicrobial agents to these patients that can simply be resolved, or at least their infection can simply be resolved with incision and drainage if it's a simple carbuncle or furuncle. But in this particular patient, he had significant surrounding erythema. He had low-grade fever. I would definitely be giving this patient oral antibiotics if I decided he did not have to go into the hospital.
Right. The other thing, we've talked about kind of the approach to management of these patients, and the other thing that should happen probably before we, besides starting him on the antibiotics, is what kind of counseling would one give to this patient? The risk of spread, hygiene. So one thinks about looking at the contact precautions for the patient, educating them on it. If they obviously have an open wound, then covering the open open wound and ensuring that there's appropriate contact precautions to avoid the touching of the bandaged areas, but also hand washing is extremely important. So there's several good educational things that we can offer the patient as we're transitioning out besides the antibiotics.
Just a pediatric comment. We certainly agree with the drugs that you've suggested. Just one thing is the tetracyclines or doxycycline, minocycline, whatever. The child has to be 8 or over because of the risk of teeth staining. But we tend to use a lot of trimethoprim sulfamethoxazole and clindamycin, depending on the proportion of strains in the community that are resistant or susceptible.
Yeah, we do as well, Carol. The only point I want to make is that if you're not as confident for sure that it's a Staph aureus or MRSA, and you're concerned that it still could be beta hemolytic strep, particularly group A strep, and if you can use trimethoprim sulfa or doxycycline, we just don't have as good confidence for that particular pathogen that is beta hemolytic strep there, and so we'll often add a beta-lactam there for the group A strep, such as amoxicillin or maybe a cephalexin, something like that. And as far as counseling patients, I tell all my patients who have even the first episode of a MRSA pyoderma to use good hand washing. I often counsel them to use antibacterial soaps. I think oftentimes I recommend a chlorhexidine type of soap. And then also to carry around the alcohol-based hand disinfectants and to use that as much as possible, because I think that does help reduce the amount of bacteria on their hands, which often can be used to transmit it to other parts of their body.
Right.
Well, thank you. That was a great case. And now we're going to move on to Dr. Feil's case.
Well, thanks, Carol. This is a more serious case than Alpesh's, but this is a case I saw, I guess, several years ago. But this is an 18-year-old gentleman at the time, anyway, who presented to our emergency room with fever and severe pain of his left hand. Now, interestingly, he was seen at an urgent care center 3 days earlier and was diagnosed as having a spider bite. And this is very common, I find, in these situations. At that time, there was a amount of erythema over the dorsum of the hand with a central papular sort of necrotic eschar, and that's why they thought he had a spider bite. Anyway, he was treated with amoxicillin, clavulanate, a beta-lactam, sent home, but over the next 48 hours he developed progressive swelling and pain and fever. Of interest in the past medical history was that he states that he had a boil about 3 months earlier that spontaneously resolved, did not require medical attention. Now, on examination, he was febrile. Temperature was 102 degrees Fahrenheit, or about 39 degrees Celsius. Pulse was 110. There was significant swelling of the lateral aspect of the hand, as you can see on this picture, with a 1 centimeter ulcer with purulent drainage coming from that ulcer. I could detect some fluctuance, and there was severe pain on palpation, and he had erythema ascending to the proximal wrist area. On laboratory studies, his white blood count was 18,000 with 12% band, so he had obviously a systemic response to his infection. Serum creatinine was 1.2. Now, the gram stain of this drainage is shown here, showing the typical clusters compatible with Staphylococcus. Blood cultures were obtained as they were in your particular patient. So with this patient, as I just mentioned, he was initially thought to have a spider bite. We see this very commonly, and that's probably because of the manifestations that you mentioned, Alpesh, due to one of these virulence factors, the panton-valentin leukocidin, that can be associated with necrosis of the skin, and for that matter, if it causes pneumonia, it can be associated with necrotizing pneumonia as well. So whenever I am approached by a patient or a clinician who says they have a patient with a spider bite, to me it's MRSA until proven otherwise. Now, the other issue is that he had a prior boil, and so the patients that I tend to see often are referred to me for recurrent disease and a recurrent furunculosis due to MRSA, and the question is, how do we approach these? And I do the same type of recommendations as I just mentioned, as far as to try to reduce the colonization using antibacterial soaps such as chlorhexidine. I will do nasal swabs to see if they're colonized there, and if they are, we'll give mupirocin.